A 55 years old, right-hand dominant woman present with complaints of pain, 3 years duration in right thumb. The pain has progressed to the point where now interferes with activities of daily living in her house and garden. The complaint of weakness of both pinch and grasp. She denies any numbness or tingling in her finger or loss of motion of the hand or wrist. Now we think about this scenario, the differential diagnosis would be carpal metacarpal arthritis, carpal tunnel syndrome, de Quervain tenosynovitis, flexor carpi radialis tendinitis, and trigger thumb. On further assessment, you assess the patient. There is tenderness and swelling over the basal joint of the thumb. Axial compression causes pain and palpable grating at the base joint of the thumb. The CMC joint is unstable to stress testing. Her thumb metacarpal is adducted at the metacarpophalangeal joint of the thumb. Hyperextends 15 degree on stress testing. Her pinch and grip strength has decreased to half of his non-dominant side. She has a negative Phelan, Tennel, and Finkelstein tests. You proceed with diagnostic studies, and the AP lateral and stress view of the thumb reveal grade 2 osteoarthritic changes of the metacarpal trapezial joint and scaphotrapezial joint with subchondral sclerosis. Cysts are present and surrounding osteophyte formation as well. A stress view which is obtained with the thumb and index at maximal pinch reveals mild radial subluxation of the first metacarpal trapezial joint. The diagnosis here is carpal metacarpal arthritis, which is pan-trapezial, with the scaphotrapezial joint being also involved. Carpal metacarpal arthritis is a common condition that has a predilection of middle-aged women. It is sequelae of idiopathic hypermobility of CMC joint. It can also be associated with trauma or inflammatory diseases. Activities that require strength or a mobility of the thumb are difficult to perform. Example like key pinch and opening a jar. Eaton has classified CMC arthritis into 4 stages. Stage 1 is characterized by no joint degeneration and articular contour that is normal. There may actually be widening of the joint space secondary to the fusion. Stage 2 is characterized by slight narrowing of the trapeziometacarpal joint on radiograph. If any joint debris is present, it is less than 2 mm in size. Stage 3 is characterized by significant trapeziometacarpal joint destruction radiographically. Sclerosis and cyst changes are noted in the bone. Stage 4 is characterized by scaphotrapezial degenerative arthritis in addition to changes seen in stage 3. The treatment of scaphotrapezial arthritis and CMC arthritis is controversial. In our situation, we prefer ligament reconstruction with tendon interposition as preferred treatment of late-stage CMC arthritis. The reconstruction of the volar beak ligament prevents thumb radial shortening and instability. The arthroplasty helps to prevent collapse of the thumb. We do perform complete trapezial resections usually, as most of patients have some degree of scaphotrapezial arthritis that may not be evident on radiograph. Incision is made bordering the thinner eminence over the first metacarpal border for about 2 cm distal to the CMC joint, curving down towards the flexor carpi radialis tendon at the wrist. The subcutaneous tissue is bluntly dissected, taking care of preserving the branches of superficial radial nerve. The abductor pollicis longus and the extensor pollicis brevis are identified and protected. The radial artery is identified in the proximal aspect of the wound overlying the trapezium. It is mobilized proximally and protected. Manual traction is applied in the thumb to identify CMC joint. The capsule is split from the trapeziometacarpal joint to the scaphotrapezial joint longitudinally. The capsule is then separatially elevated off the trapezium. Using a rounder, a trapezium is morcellized and removed. This can be done with the use of an osteotome. Care should be taken to protect FCR tendon that lies in the depth of the wound. The FCR tendon is now harvested for ligament reconstruction and interposition arthroplasty. Starting distally, 3 cm above the wrist flexion crease, the FCR tendon is identified by palpation. Incision is made over the tendon transversely. The tendon is isolated and hemostat placed beneath it, and a traction applied to the tendon. The tendon is then palpated 8 to 10 cm proximal to the first crease incision, and the second transverse incision is made. The FCR tendon is identified and hemostat placed beneath it, and the tendon is divided. At this junction, the tendon is sharply separated from the muscle belly beneath the skin bridge and with scissors. The tendon is then withdrawn into the first incision, and all FCR muscle belly is removed with sharp dissection. Traction is then applied to the tendon with the wrist flexed, and using scissors, the tendon is freed from its surrounding adhesions beneath the skin between the first incision and the wrist flexor crease. A ragnel is then placed beneath the FCR in the trapezial resected wound, and the tendon delivered into the wound. A whip stitch is placed in the tendon for each of passage through the subsequent drill holes in the first metacarpal. The thumb metacarpal is prepared for ligament reconstruction by first drilling a 1/8 inch hole in the dorsal aspect of the metacarpal base, 1 cm from the articular cartilage. A similar hole is then drilled through the articular cartilage at the metacarpal base. These two holes are now enlarged. With progressive drill bits, curettes are used to smoothen out the tunnel and that has been created to the first metacarpal. Care should be taken not to fracture the bone bridge separating the two holes of the tunnel. Now, prior to passage of the tendon through the first metacarpal, scissors are used to generally dissect the tendon free of insertion at the base of the second metacarpal. The suture previously placed in the end of the tendon is then passed through the tendon in the first metacarpal from the base of the metacarpal out distally and radially. The tendon is then pulled snugly and the first metacarpal is advanced distally. A 2-0 PDS suture is placed through the radial cortex of the first metacarpal, and the FCR tendon holding the metacarpal base is maximally adducted and distracted. After this suture is placed, an additional suture may be placed to preserve maximum distraction of the first metacarpal. A suture is placed through the capsule in the base of the wound. The FCR tendon is rolled on itself several times and sutured together with interrupted Weichel 3-0. The previously placed capsular stitch is placed through the whole rolled tendon, affixing the tendon to the base of the wound. The capsule should then be closed tightly with interrupted 3-0 Weichel sutures. The skin incision should be closed with 3-0 proline running subcuticular stitches. If preoperatively the thumb metacarpal joint is found to be hyperextended more than 15 degrees, this should be addressed surgically. It is our opinion that the instability of 15-30 degree of metacarpophalangeal joint hyperextension should be treated with a Wöhler plate arthroplasty. Cases with greater than 30 degree of hyperextension should be treated with the metacarpophalangeal fusion. To accomplish Wöhler plate arthroplasty, previous trapezial arthroplasty incision is extended distally along the midaxial line of the thumb of the metacarpophalangeal joint. Flexor polysomnographic tendon and the neurovascular bundle are identified and protected. The sheath of the FPL at the MP joint is opened at its insertion and retracted palmarly. The Wöhler plate is identified. Metacarpophalangeal joint is flexed 30 degrees and pinned with a 0.6 inch K wire. The Wöhler plate is then reefed using 2-0 PDS sutures. The sheath is closed with the interrupted 3-0 Weichel suture and is the subcutaneous tissue. The skin is closed with running 3-0 proline subcuticular stitches. K wire left there for 3 weeks postoperatively. At the conclusion of the procedure, the patient is placed in a bulky dressing and the incorporating thumb spica splint may be applied. 1 week post-operatively, the sutures are removed. The patient is placed in short-arm thumb spica cast for additional 3 weeks. At conclusion of plastic immobilization, a custom-made orthoplast forearm splint is fashioned. This is worn except when the patient is bathing. Over the subsequent 2 weeks, the patient is weaned off of the splint, and at 6 weeks, strengthening exercises are begun, and at 12 weeks, the patient is free from all restrictions. There are different types of operative interventions for CMC arthritis. We should mention some of them. One is isolated ligament reconstruction. This helps recreate volar peak ligament and restore thumb stability. This does not address any degenerative changes and is for early disease only. Then is tendon interposition only. It's technically easy but does not maintain the height of the thumb metacarpal. Then is ligament reconstruction with tendon interposition. This maintains height of the thumb metacarpal, restores ligamental stability, and technically it's more difficult. Then is ligament reconstruction with no tendon interposition. There is less dissection, space remaining FCR, and up till now only 3 to 4 years follow-up has been reported. Another option is hemiresection of trapezium. In this case, bony support is maintained and space scaphotrapezial joint. This has this advantage that if missed scaphotrapezial arthritis, salvage is technically more difficult. Then is the option of ligament interposition, ligament reconstruction with silicone interposition. This has a disadvantage of silicone synovitis and implant fracture and failure. Other option is CMC fusion, which maintains strength, but there is loss of mobility. This is for a young patient with no scaphotrapezial arthritis. Talking about the complication of LRTI. This includes infection, collapse of the thumb ray, and secondary hyperextension of metacarpophalangeal joint. Reflex sympathetic dystrophy is a devastating